Hello, and thanks for joining us today for our webinar on research and clinical advances in LSVT LOUD and LSVT BIG. My name is Laura Gousset. I'm a physical therapist and one of the LSVT BIG instructors, as well as the Chief Clinical Officer of LSVT BIG. And I'm joined today by Dr. Cynthia Fox, who is an LSVT LOUD speech therapist and CEO and co-founder of LSVT Global. So we're so grateful that you've joined us. And we hope that this next hour is informative and exciting to learn all of the new research on both LSVT LOUD and LSVT BIG. Briefly, Dr. Fox is an expert on rehabilitation and neuroplasticity and the role of exercise in the improvement of function consequent to neural injury and disease. She is truly a world leader in LSVT LOUD, and she has conducted many of our efficacy trials related to LSVT LOUD and LSVT BIG and Parkinson's and other disorders. She is faculty for both LSVT LOUD and LSVT BIG training and certification courses, and she now serves as our CEO and co-founder. So delighted to have Dr. Fox with us, as she's been so integral to the research on both treatment programs throughout the last 3 decades. I myself am a clinician who has had extensive experience treating patients with neurodegenerative disorders, especially Parkinson's and multiple sclerosis over the last 15 plus years. I myself was certified in LSVT BIG in 2009 and have been an instructor for LSVT BIG since 2011. So I enjoy my job being able to host webinars like these and help to develop curriculum and products to help people with Parkinson's and also to train clinicians in LSVT BIG. We are very grateful for the funding support that LSVT Global has received over the years that make all of this research possible. And some of these organizations are listed here, and truly it's a team effort between researchers and people that fund research and clinicians that deliver the treatment, and also the patients that receive these treatments. A few disclosures: Dr. Fox and I both have financial and non-financial relationships with LSVT Global, including a preference for LSVT BIG and LSVT LOUD as treatment techniques. Dr. Fox and I are both employees of LSVT Global and receive lecture honorarium, and Dr. Fox has ownership interest in the company. Some brief logistics for today's webinar, in case this is a new webinar for you or you haven't joined us before. You will see a control panel probably on the right side of your screen. If you haven't received the handout by email just prior to this webinar, please note that you can download it from the handout section on your control panel and save it, print it, make notes, whatever you'd like. This webinar will be recorded as well, so in case you want to go back and review the content or share it with other people that might be interested, you'll be able to find this webinar in about 1 to 2 days in our blog, which is blog.lsvtglobal.com, or you can email us at any time and we can send you the link to the recorded webinar. Some other logistics and housekeeping. Right now, all of your microphones are muted so that there's no background noise from the various environments from which you might be joining us. However, at the end of the webinar, we hope to leave some time to answer your questions. Feel free to type in your questions at any time during the webinar, and we will stockpile these questions and answer as many as we can at the end. You will also have the opportunity to ask your question out loud at the end of the webinar by raising your hand. So if you raise your hand right now and you notice that we're not answering you, just know that we do see you. Keep your hand raised and we'll get to you at the end of the webinar and give you some information on how you can speak that question out loud, and either Dr. Fox or I will answer your question. A note for clinicians that are joining today's webinar, thank you for coming. If you are an LSVT LOUD or LSVT BIG certified clinician, please note that we did have a professional webinar on this topic. For LSVT LOUD, our webinar was held yesterday, and for LSVT BIG clinicians, our webinar was held on Monday. Those webinars are both available through your clinician account and are a bit more specific and more in-depth than this webinar will be today. So feel free to stay on this webinar, but feel free to check out that one as well. The bulk of our hour is going to be spent presenting the content, followed by answering your questions. and giving you some other information at the end related to our courses. There will be a brief survey that will also pop up at the end of the webinar when you exit. So please do take the time to answer the survey. We're always very grateful for the feedback that you can provide us so that we can continue to make our webinars better. If you are a therapist joining us today, here's some information on how you can self-report your CE activity. Please note that the webinars are not ASHA or state registered for speech, physical, or occupational therapy professionals, but you can use this information to self-report your CEU credit as a non-registered or non-pre-approved CE activity if your state allows that. If you'd like a certificate, just email us at webinars@lsvtglobal.com to request a certificate, and we'll send one electronically. It'll include your name, the date, and the duration of the webinar. Also, you do have to attend the webinar for the full hour to earn that CE certificate. Our learning objectives for today are as follows. By the end of this webinar, you should be able to, sorry about that, just skipped a slide, to define evidence-based practice and differentiate between guideline and protocol-based therapies. We'll briefly review foundational LSVT LOUD and LSVT BIG research and describe this research, provide a rationale for how LSVT research supports and benefits both clinicians and patients, and finally summarize future research and clinical innovations. So before we kick off the webinar, now that you know a little bit about us, we would really like to know a little bit more about you too. So in just a moment, I'm going to launch a polling question, and it's very simple. We just want to know if you're a speech therapist, PT or OT, a person with Parkinson's disease, a family or friend of someone, or someone else. So just give me 1 minute, and I'm going to launch that poll. Okay, you should be able to, let's try that one more time. I think I might have closed it too soon. So I'm going to try that one more time. Okay, so I think I might have messed up there, Dr. Fox, on the poll. So with that, we'll just say we welcome you regardless of who you are, if you're a speech, physical, or occupational therapist, or a person with Parkinson's disease, or someone else. So with that, I'm going to pass it over to Dr. Fox after I hide this poll here.
Thank you, Laura. No problem on messing up the poll. Sometimes that happens. But as Laura said, we welcome you all very much to the webinar and are excited to share some of the new updates. And if any of you are completely new to LSVT LOUD and LSVT BIG, we'll also provide a brief background, as Laura said, on some of the foundational research. So we recognize that today, up to 8 million people worldwide are living with Parkinson's disease, and this prevalence is expected to double by 2040. So there's a great need for treatments with proven efficacy to help improve communication, mobility, activities of daily living, etc., for people with Parkinson's. Our mission at LSVT Global is to empower people with Parkinson's to both restore and maintain their highest levels of functional communication, mobility, and independence with activities of daily living through scientifically supported rehabilitative treatment programs. So our specific work and the specific focus of the research updates we'll be providing today are for LSVT LOUD, which is our speech and voice therapy, and LSVT BIG, which is our physical and occupational therapy. And we know that research is really essential to provide the strong foundation we need as therapists to provide the best possible treatments to those living with Parkinson's disease. So research is one component of one piece of the puzzle, but there also has to be that translation to clinical implementation. So to have the research studies, to have them published in journals, doesn't help people living with Parkinson disease and those of us who serve them if we can't translate that to clinical practice. So as clinicians, as well as people with Parkinson disease, sometimes we wrestle with, how do I choose which evidence-based treatments to use as a therapist or receive as a person with Parkinson's? And some questions to think about and consider are the amount and quality of research that's available, the feasibility for the clinician and the person receiving the treatment for completing the treatments that are being offered. Is the treatment reimbursed, and what's the cost of the therapy that's offered? Is it accessible in my area where I live? Are there any ethical or safety issues that need to be considered? In light of those questions, we want to offer you some general resources that are available, free, online, independent, which should theoretically be non-biased reviews of evidence. And one of them is through the American Speech Language Hearing Association that offers ASHA evidence maps. The link to this is on the slide, and once you're in the evidence maps, you can select specifically, I want to know Parkinson disease, I'm interested in speech and voice treatments or swallowing treatments for Parkinson's. A similar type of evidence map out of Australia is SpeechBite. So these are, again, open, freely available to the public as well as therapists to go in, and someone has done some of the work for you to show what evidence, current evidence exists to support treatments for Parkinson's. For physical and occupational therapy, there are also evidence maps. For OT, the otseeker.com, and it's a database, again, that contains abstracts of systematic reviews and randomized controlled trials. Similarly, pedro.org.au is a physiotherapy evidence database. And again, once you're in these databases, you can select the Parkinson disease, or if you're interested in something else, and learn a little bit more about the evidence that exists for these treatments. So for example, one of these studies for LSVT BIG comparing exercise and Parkinson disease, and this was a foundational study, in the Pedro, you can see how it's looked at all the criteria and rates for you. It's a 6 out of 10, so a moderate degree of evidence supporting that treatment approach. The other term that we're very familiar with, both I believe as clinicians and people with Parkinson disease, is the idea of evidence-based practice. And so evidence-based practice is a triad. It takes into context clinical experience, what the clinician knows, patient values, so what's important to the person who's seeking the treatment, and best research evidence, so what's in the literature. And we use evidence to design our treatment plans, of course, and that's what the external evidence is important for. But it's more than that, because it is a dialogue between the practitioner and the person receiving the treatments. So our job as practitioners is to provide all of the information and then have the conversation, allowing the person with Parkinson, given the evidence that's provided, to choose what works best for them. In the past, when we talk about evidence, we focused a lot on models for outcome research, classes of evidence, and sort of how to kind of work your way through that. And what we're providing to you today is the discussion about guideline and protocol-based therapies. You know, are they the same? Are they different? And what impact does that have? And so guidelines are statement or other indication of a policy or procedure by which to determine a course of action. In this case, you may, if you want to, use parts of the guideline. It doesn't require compliance, allows for deviations at the individual therapist's discretion, but cause-effect behaviors in research might be more difficult to define, as there may be variations in the delivery of the treatment. So some nice example of guidelines, and this is just one example of many, are the European guidelines for Parkinson disease, which exist for PT, OT, and speech. In contrast, a protocol is more precise and detailed plan for the study of a biomedical problem or for a regimen or therapy. In this case, it's more you shall do these certain behaviors, and it requires compliance to predefined research set of behaviors, allowing for review of compliance with these behaviors. Protocols might be able to be researched a bit more precisely for cause-effect behaviors. And our treatments that we'll talk about today, LSVT LOUD and LSVT BIG, fit more under protocol-based treatments. Now, some considerations. One is not better than the other, so it's not a superiority contest. They're just different types of ways to deliver treatment. And oftentimes, guidelines start as the basis of what may eventually develop into a protocol. As I just mentioned, LSVT LOUD and LSVT BIG fall more under the umbrella of research protocols, and thus treatment behaviors are more clearly defined and outcomes can be predicted in the populations that have been studied. Now, a protocol system is not completely rigid and inflexible. In fact, it does allow for personalization. And in fact, therapists must think independently when using protocols and use their good judgment. While they're following the protocol per se, they do have options for personalization that can enhance the protocol, not replace what was researched. So our research journey has been over 30+ years from the initial invention that was led by Dr. Lorraine Ramig to the scale-up that exists today. And this is just sort of a plot of our initial work, our hard research years that included a number of randomized controlled trial, and the works that we do today in terms of clinical implementation. So in terms of the foundational LSVT LOUD research, and this again would be for individuals who may be new to LSVT, includes 3 randomized controlled trials. I'm just going to highlight key points of these studies as I want to get to some of the newer studies. The first trial in the top graph was 45 subjects where we compared LSVT, which had a voice and respiratory target focusing on loudness, versus driving the respiratory system alone to achieve loudness. We studied individuals pre, post, 6, 12, and 24 months after treatment with the measure, which is on the y-axis of all these graphs, decibels of sound pressure level. So the higher up the points on that graph, the louder individuals with Parkinson's disease were. And we found in this first trial, pre, post, and up to 2 years, that individuals who received LSVT LOUD were louder than the alternative treatment of respiratory. In the second randomized controlled trial, we compared LSVT LOUD to no treatment, following individuals out to 6 months, and we had similar findings of individuals who received LSVT LOUD were statistically significantly louder and maintained that out to 6 months. Our most recent randomized controlled trial on the bottom graph compared LSVT LOUD to an articulatory high effort treatment to no treatment, and we found that LSVT LOUD was superior to the Artic for improving vocal loudness, and it was also statistically significantly maintained above pre-treatment level. So the keys with randomized controlled trials is that they allow us to start to tease apart what's most important for successful treatment. So the studies are matched in dosage, intensity, homework, therapist enthusiasms. We have repeated measures for reliability, uncued tasks, and data collected by someone other than the therapist. So what does this research tell us? In short, what we do in therapy matters. So it's not just activity or speech instruction in general, specific activity matters. So thus far from these studies, we've found that our research would suggest that that focus on voice with that respiratory laryngeal target is special versus the same intensity focused in either the respiratory system or articulatory system. So voice focus and the sensory calibration that's part of LSVT addresses these sensory motor integration deficits affecting the self-perception or autophonic perception of normal vocal loudness. And we believe, based upon our imaging data that are not presented here, LSVT LOUD may provide a cortically driven enhancement of the sensory motor and auditory speech motor network.
Okay, thank you, Cynthia, for that nice summary of the foundational LSVT LOUD research. And I'm going to briefly do the same, but for LSVT BIG, which is newer than LSVT LOUD. Thus far, we have 2 published randomized controlled trials. Both were published by Ebersbach in movement disorders. The first that you'll see was from 2010, and the second from 2014. Now, you may be familiar with this study, but in case you're not, I'll give you a little description here. You will see 3 lines, a solid line, a dotted line, and a dashed line. So this was a randomized controlled trial where there were 3 groups. One group did LSVT BIG, so 4 times a week for 4 weeks, 16 sessions. The other group did Nordic walking, also 16 sessions, but twice a week for 8 weeks. And the other group did an unsupervised home exercise program. The primary outcome variable in this study was the UPDRS motor score, which is a motor score that neurologists use for assessment to assess progression of Parkinson's symptoms in the motor domain, as well as response to anti-Parkinsonism medicines as well. So a decrease in the UPDRS score is actually an improvement in motor function, or a less severe motor function problem. So on the bottom line is the dashed line is the LSVT BIG group, and you can see that that group is the only one that decreased, which means they showed improvement in their UPDRS motor score. The amount of change was both statistically and clinically significant, whereas the Nordic walking group and the home exercise program group remained about the same to got slightly worse over the course of the study, which was 16 weeks long. You can also see that there was a trend for continued improvement over the course of 16 weeks with the LSVT BIG group, even though the treatment intervention ceased at 4 weeks. The second of those studies also compared LSVT BIG at a traditional dosage of 4 times a week for 4 weeks to a modified dosage of 5 times a week for 2 weeks. So it was called a shortened training protocol, but they did the exact same things within the session as in the regular training protocol for LSVT BIG. What was interesting with this study is that the motor scores on a number of outcome measures improved in both the LSVT BIG group and the shortened training protocol group. However, when they looked a little bit deeper at the patient's own perception of whether they had improved or not, there was a huge difference between the shortened training protocol group and the LSVT BIG group. So by the end of the treatment study, over 70% of patients that received LSVT BIG per protocol of 16 sessions rated themselves as very much improved or much improved, whereas only 17% of patients in the shortened training protocol rated themselves in those same 2 categories. They also looked at a physician's impression of whether the patients had improved, and it was a very similar pattern that the physicians could tell through observation of the patient that they weren't moving as well as the ones that received the full LSVT BIG protocol. Some of the strengths of these 2 studies were that the data analysis was by a blinded rater. The outcome measures for gait were uncued, and the data was collected by someone other than the treating therapist to reduce or eliminate the bias. So what does this research tell us, and what do we do? What we do in therapy really does matter, and that's really at the heart of all therapists, is a heart to help people function better and move better in everyday life. And so through these studies, we have seen that training amplitude, which is moving bigger, improve speed and efficiency of gait and transfers. And for someone with Parkinson's, that is really significant, to be able to move at the same speed as your peers more efficiently and not struggle to get out of a chair. And interesting that you can do that by training someone to move bigger, that speed naturally improves along with it. The second of these points is that intensive training and adequate repetition of practice is needed for recalibration of the sensory motor system so the patient can perceive changes in function. And I always feel like, outcome measures are important, but what is really important is the patient's function in everyday life impacted so much that they can tell. And we know that in that shortened training protocol group, both arms were treated intensively 4 or 5 days a week, but the repetition of practice clearly was key in the LSVT BIG group. And lastly, low intensity or unsupervised exercise programs may not be as beneficial in improving mobility or motor function in people with Parkinson's disease. We've seen it in the 2010 Movement Disorders Berlin BIG article. We've also seen it in other exercise studies on Parkinson's that weren't LSVT BIG as well. If you want to review all of our resources and references on the foundational research, we'd welcome you to visit our blog or the ASHA Academy, and we've listed both of the links here. So in case you want to copy and write those URLs in and go, you can really dig in and find some very interesting articles, some of which are open access articles if you don't have access to a university to pull research.
So what's new? Let's dig in now and talk about some of the new studies that are out there. And I'll start with LSVT LOUD and some of the studies that are new. And I'll just preface this by saying, in the interest of time, both Laura and I will be giving very high-level overviews of these studies. If you are particularly interested in a specific study, please ask a question or request us to send more information, provide more details. We're absolutely happy to do that. So let's start with some technology updates and some new publications that came out in 2019. The first one was a group out of Australia that looked at speech maintenance via telerehabilitation. And this was a pilot study. And in short, it was a feasibility study. And they had 8 participants who had completed LSVT LOUD within the past 6 months. Now they entered them into a maintenance program, which was 2 90-minute online sessions a week for 4 weeks. And the key here, this was all done via telerehabilitation. They measured things such as vocal loudness before, immediately after, and a 3-month follow-up period from this maintenance online program, and looked at measures of loudness, which is SPL or sound pressure level. And they found that actually these patients, even after they've completed LSVT LOUD, continued to improve their vocal loudness from pre to post for long ahs, reading and conversation, and that loudness was maintained for even 3 months after the end of the maintenance period for ah and reading. The other thing they wanted to know, did people like this method of online group maintenance? And they had very high satisfactory ratings for the telerehabilitation setting. So the high-level conclusion was that this may actually be a feasible way to help people after they've received LSVT LOUD maintain through telerehabilitation practice of their voice with the potential to improve and or maintain loudness. And that work is ongoing now into the next phase from this group out of Australia. Another type of technology study that was published in 2019 came out of Sweden. This group was looking at a portable voice accumulator. And basically, in short, it's a device an individual can wear that monitors their voice activity and vocal loudness outside of the therapy room. So in this study, it was a prospective, what they call a single case experimental design, just with one person with Parkinson's and a healthy control, and the individual wore this device a week before treatment, during all 4 weeks of treatment, immediately following treatment, and that at various time points after the treatment was over. And they looked at the differences and increases in vocal loudness that were the individual with Parkinson's disease had outside the clinic versus inside the clinic. So immediately post-treatment, they had a 4.1 decibel increase outside the clinic, 5.6 inside the clinic. And 1 year later, and this was without additional treatment, had maintained up to a 1.4 decibel outside the clinic and 3.8 decibel inside the clinic. So this highlights two things. One is when people come into the clinic and we do these measures as part of our research, we know we get an increase in loudness likely because of the clinical setting, people know their voice is being tested. There's no sort of real world dual tasking. And that outside the clinic, that loudness may decrease, but it's nice to be able to document it's still above pre-treatment levels. So this was just a sort of first step toward looking at ways to be able to monitor outside of the clinic behavior in real world activity. Some other studies that have come from external labs, one group, Mike Canedo and colleagues, looked at new ways of analyzing phonation or voice in Parkinson's disease. And this is spectral cepstral analysis. And so speech scientists love these types of measures. But in short, it was a small group study, 9 participants that were examined pre and post LSVT loud. And they measured sustained vowels. So that, for example, is going and they take these vowels and measure them for very specific acoustic parameters. In this case, for example, cepstral peak prominence. And what they found was that they were able to identify improvements in things like harmonic structure and voice quality post-treatment. So this was just a way of taking a new type of analysis and applying it pre-post LSVT to see what we could document, and indeed showing improved vocal quality consistent with non-Parkinson's speakers following vocal loudness training. The importance of that is, you know, some people have concerns, wow, if you're training loudness, might you harm or make a person's voice worse? And the reality is, under the care of a speech language pathologist who has been trained for many years to improve voice quality, we in fact see that we can have healthy and improved vocal quality with vocal loudness training. The last study that I'll show here on this slide was a group out of Iran. So we had very international publications this year. This group was from the University of Iran, and it was basically their first look at LSVT loud in their country and with Persian speakers. We often have questions, you know, this is a US developed treatment. Does it only work in English speakers? Does it only fit one type of culture? And they had 23 participants, 13 who were treated with LSVT loud, 10 untreated. All of those individuals had Parkinson's disease, and they compared them to 13 non-Parkinson's disease speakers. Their measure was a perceptual self-measurement of what's called voice handicap. And they looked at the measurements pre and post-treatment. And first of all, they found that before therapy, all speakers with Parkinson's disease rated their voice handicap worse than the healthy speakers. So they felt that the impact of Parkinson's disease or their voice disorder on communication was more challenging than those without Parkinson's. What they found was after LSVT loud, those individuals with Parkinson's disease who received treatment had significant improvements in their self-perception of voice handicap. So conclusions were improvements in voice handicap post LSVT loud may reflect improved self-monitoring and self-regulation of voice, and it also adds for us another multicultural linguistic data in Persian speakers that LSVT loud can be successful as well. A study that was not published in 2019, but was just accepted for publication, so it's what we call in press, will be coming out in early 2020, was looking at speech intelligibility post LSVT LOUD. We can study speech intelligibility in many, many ways, and oftentimes the listeners in those studies are trained speech-language pathologists or students in the field of speech-language pathology. So some criticisms of those types of studies: does it replicate what everyday on-the-street listeners would perceive as well? So in short, this study used some previously published data of ours and pulled the words key and stew from these classic sentences that we collect, and they used crowdsourcing at 36 online, what we would call naive listeners, who rated these paired samples and simply rated which one they perceived as more clearly articulated. And the results show, and these are box plots showing the outcomes for the word key on the left and the word stew on the right. And the next, there we go. And the black line in the middle of the box is the median, but overall, naive listeners rated more clear articulation for the post-treatment samples, both for the word key and for the word stew. So this study really evaluated kind of ecologically valid listeners outside of highly trained can notice changes in speech articulation. The next study that we'll look at looked at cognitive linguistic contributions. And this is a study that preliminary analysis. In very short, we collected language samples pre-post LSVT LOUD in treated and untreated healthy controls, and wanted to know simply, do we see changes in language? And what we found was, in our preliminary analysis, yes, there are some suggestions that language changed in terms of mean length of utterance for words and morphemes, and an increased use, next slide please, of verbs. So this is very interesting and something that will be studied in more detail, but the idea that strengthening of the semantic representation of physical actions that we achieve through treatment may actually improve access to verbs in people with Parkinson's disease. Next slide. So in summary, you know, what's exciting is while we have very solid scientific evidence in randomized controlled trials and a number of other studies for LSVT LOUD, we keep continuing to learn more, and that should inform our clinical practice to improve what we do. So what we learned this year, technology may enhance maintenance of LSVT LOUD and our ability to monitor real-world carryover. We see more evidence of spread of effects in voice quality, speech intelligibility, and potentially language. And this helps enhance our confidence as therapists that by keeping our focus on that single therapeutic target, we can have efficiency of treatment. And then the additional findings in different languages, Persian being added this year, suggests that the target in LOUD may be universal due to the fact we're actually targeting underlying hypokinesia, impaired self-perception of vocal loudness, which is important across all languages. And with that, oh, one more slide. This is just summarizes some of our ongoing future work. We look to have some more publications from our randomized trial in 2020 and some ideas for other future types of research. We might look at non-motor scales, continued work in technology, and continued work for maintenance groups, in particular our Loud for Life studies. So with that, I'll turn it over to Laura to tell you what's new with LSVT BIG.
All right, Cynthia, thank you. So in 2019, there were 4 additional articles which were published on LSVT BIG. 2 were single subject experimental design studies and 2 were other case studies. And so I'm going to briefly go through those as Cynthia did. One of the themes I think you'll notice for all of them is the theme of really personalization of functional goals and tasks. And if you remember back towards the beginning of our webinar today when Cynthia was talking about guidelines and protocols. She made the astute point that a good protocol has the option to enhance it and personalize it for the patient. And I hope that you notice that in each of these 4 really interesting case studies. So this first case study was actually using LSVT BIG on 2 clients that had stroke years ago, one 3 years ago and one 12 years ago. This is interesting because it is only the second case study that's been done on stroke using LSVT BIG. All of our other articles have focused on the use of LSVT BIG in the Parkinson's disease population. Also interesting, of course, is that if you think about a typical person per stroke, with stroke, they undergo a number of sessions of rehabilitation, inpatient, outpatient, but even years later, you'll see that they had potential to improve. So in this study, LSVT BIG was delivered by occupational therapists, and the patients had the opportunity to choose their own tasks that were meaningful to them. So LSVT BIG purposefully trained 3 out of 6 of those tasks, and they looked at improvement in both the trained and untrained tasks using 2 measures. One is called the Canadian Occupational Performance Measure, and the other is called the Everyday Arm Use in the Community and Home. They were measured repeatedly, and the assessments were either self-assessments or by blinded raters. So you might be wondering, like, what particular type of activities were these 2 individuals able to improve upon? The client that had a stroke 3 years ago improved upon many things. So he reported he could now clean out his garage, his shed, bathroom, laundry, prune trees. He could light a campfire, chop wood, and do basement renovations. So really high-level, complex tasks that were meaningful to him. The other client was a female that was 12 years post-stroke, and she really used LSVT BIG to learn a strategy to help her with everything in everyday life, even tasks that they hadn't trained. One of her quotes that she said is that it helped her not to further injure her tendonitis, which she had had for a long time. It encouraged her to use her arm rather to stop and avoid the activity because of the tendonitis, and it gave me the confidence to try a new movement because I had the knowledge of how to do it. I was unsure about what I could learn, but I could see improvements in control of my elbow and my balance on the bike, and I did not expect that progress would happen in 4 weeks. So really quite exciting to see those comments from the 2 clients. The next study was looking at improvements in dynamic balance and gait speed in 2 individuals with Parkinson's disease that underwent LSVT BIG. So this was a 3-phase design where they established a stable baseline for 2 weeks prior to treatment. Then they did 4 weeks of LSVT BIG, and then they had a post-intervention phase of 6 to 7 weeks where they were assessed at multiple time points throughout both the pre and post phases and the intervention phase. The 2 outcome measures they looked at were the mini best test and the 10-meter walk test fast, and those improved significantly in both groups. Clinically, it was very relevant because they surpassed the cutoff scores, meaning that they weren't any longer considered at fall risk. Both clients continued to improve in phase C of that study, which was the post-intervention phase, because of their continued exercise. The next of these studies, I'm just going to move to the next slide, looks at the impact of LSVT BIG on functional outcomes in a person with Parkinson's disease. This one was really interesting to me as a therapist because it was a clinical case study. So it was like real world patient selection. A lot of times in clinical trials, the exclusion criteria are fairly wide, and it limits the amount of people that can enroll in the study. But this client was very complex. You can see they had a past medical history with multiple comorbidities that could impact his overall health and well-being and function. They looked at a number of outcome measures, including the TNETI, the functional reach test, the 10-meter walk test, and despite all of those comorbidities, he was still able to exceed what's called the minimal detectable change and showed a 13-second improvement in his timed up and go. and became independent with many of his functional tasks. This was a table from the study where you can see the amount of change in each of these outcomes, which is significant to have, a 13-second drop in the tug, 5-point improvement in Tonetti, doubled his functional reach, improved his sit to stand speed. In other words, initially it took him 18 seconds to get out of the chair 5 times, and he cut that in half by the end, able to walk further and able to walk 3 times faster as well. But functionally, that functional impact is really what is most important for our patients. He was struggling with stairs, and he was able to gain greater independence and confidence with that. He became independent and faster with his bed mobility and transfers, which allowed him to get up out of his recliner more easily. He could carry a glass of water and sit down without spilling, get in and out of the car, and also keep up with his wife. Even though he was still using the walker, that was an important goal for him to be able to achieve. This next study here is another case study on looking at occupation-based measures. So those are measures that occupational therapists use to address function that's personalized to each individual. This was also a person with Parkinson's disease, and they used those same 2 assessments as you saw in the other study, the COPM and the PASS. And in this study, the client had improved perceptions of their performance and satisfaction on the COPM that were both clinically significant and showed improved independence on the PASS. Now, there is no minimal detectable change data on the PASS, but the treating therapist found improvements in the patient's rating of that as well. Functionally, this client was really interesting. She was living independently on a farm, taking care of horses, driving, taking care of her house, her meals, etc. She was able to do those things prior, but she was very slow. And her goal was to be able to do those things more efficiently and independently, which she was able to do. Some emerging work. So this is a study that's in preparation to be published. Also, you'll notice a theme here, also looking at occupational performance, extremely important. This was a retrospective chart review looking at 66 individuals who had completed LSVT BIG, the 4-week protocol. And if you'll notice that on the bottom left side of the slide, it says 72 to 75% of occupational performance priorities fell into the self-care category. And what that means is that activities involving caring for oneself are a high priority in individuals with Parkinson's disease. Those top areas of concerns related to handwriting, walking, balance, getting oneself dressed, buttoning fasteners, and transfers. And if you're a therapist listening to this webinar today, you know how relevant those activities are for many of our patients with Parkinson's disease. In this retrospective chart review, they did find significant changes in their perceived occupational performance and their fine motor skills in the data reported in those patient charts. So what are we learning and how can we apply this to practice? And this is really the most important thing. We're beginning to see this early research that LSVT BIG may be feasible and applicable in other neural populations like stroke, but certainly lots more work needs to be done, and it would be wonderful to see a randomized control trial in the future. Therapists should really carefully select your outcome measures which have a lesser risk of a ceiling effect, and we should be assessing all types of balance, including dynamic balance and not just static balance. For OTs, we should be including occupational performance-based measures, focusing on client-centered goals and not just impairment-based measures. And if you're an LSVT BIG therapist listening to this webinar today, really consider the collaboration between OTs and PTs. And if you're looking to comprehensively address your client's needs, it's a really beautiful thing to be able to work together in delivering LSVT BIG as if both of you are certified. In terms of future LSVT BIG research, the future is wide open, and here are some ideas here. A randomized control trial of LSVT BIG compared to another evidence-based therapy approach or exercise approach, looking at the impact of fall prevention, freezing of gait, activities of daily living. non-motor symptoms of Parkinson's disease. How long do the treatment effects last? Is there effects on aerobic capacity or lower extremity strength? Can impact long-term symptom progression, and can Big for Life impact long-term outcomes for patients as well? So with that, I'm going to turn it back over to Cynthia.
Thank you. So let's wrap this all up here in our last 10 minutes. And we like to say we're in this together. The research is there to help you, to help therapists, to help people living with Parkinson's disease. And one of our goals is to try to kind of demystify what this research thing is and talk about really how does that translate to clinical practice? How does that translate to clinical outcomes? And so, we have kind of these 6 key reasons that LSVT research can support therapists. And the first one is it really does provide therapists with assurance they're providing patients with treatments that work, based upon strong research evidence to support its efficacy. By having research, it gives therapists confidence, and that confidence oftentimes comes in providing intensive treatments and sufficient repetitions, which are required to have lasting changes. And it's not uncommon. In fact, when we train clinicians, we say, okay, about week 2 or week 3, you're going to start thinking, gosh, do I have to keep doing this repetitions? Is this really essential? And again, it goes back to the research, gives you that confidence to stay the course so that you can have outcomes matching what have been published in the studies. And so we've shown through multiple randomized trials, or beginning to start to see the cause and effect relationship between the treatment delivered and the outcomes measured. And I think the LSVT LOUD studies have really shown that, in that we see you can have the same protocol, but different targets, be it loudness, respiratory, articulatory, and the outcomes are different. So that's what we mean when we say it helps us tease that apart. It dispels concern of research bias when we have similar improvements in studies being done from multiple laboratories and countries, and that provides some initial or some external validity of the research results. It supports these core components of treatment that were a solid neuro-based treatment by having application in other neurological populations, and it offers confidence that technology does not diminish the effectiveness, and at this time for LSVT LOUD. If you're a person with Parkinson's disease, how does research help you? Well, it can offer clear expectations of treatment requirements. So you know what you're signing up for, and you know the potential therapeutic outcomes you can receive if treatment is delivered via that protocol. It also gives you confidence that this repetition of training and calibration are required to make those changes that last. It allows people with Parkinson's or family members to advocate for practices that prioritize and offer evidence-based therapy treatments, and it can protect physical, financial, and emotional resources by being able to participate in treatments with efficacy versus potentially less effective treatments. So as always, knowledge is power. And Laura, I'll turn it back to you to close the show.
All right. So really, we hope that you've seen in summary that it's essential in our field that we develop research-based treatments that are based on solid evidence and theory. And that's great, but you can have the best model and theory in the world, but you still have the crucial questions are, can you as a therapist learn how to correctly deliver the treatment and implement it? And for patients, can patients participate in it? What's unique about the LSVT protocols is that the answer is yes. And if you're not certified and you become certified, you'll learn in the courses that you can help people with early stage Parkinson's all the way through the later stages of Parkinson's disease. And we do have emerging research and implementation through our training programs. The research outcomes and clinical knowledge from our clinicians are what continue to feed successful implementation. And because of this, people with Parkinson's and other neural disorders benefit. But there's always more that we can learn, more that we could do. And if you're interested in research, we would love your help. So now we have a few minutes to ask questions. Here's just some reminders of how you can ask questions. You can type it into your control panel. You can raise your hand. So in order to do that, click on the hand icon. Your name will be called out so that you know that it's your turn. Please remember to unmute your microphone, and we'll do it on our end as well, and then you can ask your question out loud. If there's something else you want to ask on a different topic, or if you think of a question later, please do email us anytime at info@lsvtglobal.com, and we will direct your question to one of our LSVT LOUD or LSVT BIG experts. So while you're typing your questions, just a few reminders. If you're looking to learn more about LSVT LOUD or LSVT BIG, we do have monthly live webinars. Our 2020 schedule will be out shortly. In the meantime, you can access all of our on-demand webinars through our blog. There's also information on our website, and we would love for you to join one of our live seminars. So if you are interested, if you're a person with Parkinson's, please look at our blog under events and see if a live seminar is coming to your area where you can hear straight from our faculty and actually have a chance to participate and try the LSVT LOUD and LSVT BIG exercises with therapists who are attending a training course in the same weekend. And lastly, we also have a Facebook page that we'd welcome you to check out. Here's a listing of our upcoming future courses if you're a PT, OT, or speech therapist or student in those professions, and information on where to find those free seminars as well. So with that, I'm going to open it up for questions and see if there are any that came in. Very helpful to know that's accessible as a clinician. Thank you. Thank you, Katie. Right now, I don't see any other questions coming in, so I'm just going to check our time here. It looks like we are close to the top of the hour, but I'll give it another minute. And Dr. Fox, is there any last parting words that you'd like to offer this webinar?
Well, we thank you all again for joining us. We love research. We love what research beyond just LSVT LOUD and LSVT BIG has done to raise the awareness and the value of exercise, rehabilitation, speech, physical, occupational therapies for people with Parkinson's disease. So thank you for joining us on learning more about our specific research, and we hope you join us for another webinar in the future.
There is one last question that came in, Cynthia, and I think we have a minute to answer it here. At the Aphasia Center where I work, there's currently a client who has a diagnosis of PPA, parentheses, CBD. His voice is getting quiet fast. Would LSVT LOUD be appropriate for him?
Excellent question. What we train in the course, and my answer to this would be, I don't know. We always look at the qualities of the individual, their speech, and are any of those consistent with hypokinesia, soft voice, mono loudness, reduced loudness. Oftentimes when we have a diagnosis, and typically it's when we're frustrated because everything we try isn't working that people turn to LSVT, we do some stimulability testing. So I'd have the person try some of the exercises, some of the techniques, see how they respond. If we like what we see in stimulability testing, then we move to a period of trial treatment. And typically trial treatment is a full week, 4 days a week for 1 full week of the LSVT LOUD protocol. I like to schedule trial treatment with the intent that the whole month is available. So if the trial treatment is moving in a positive direction, we can then simply continue and move on with the therapy. The key here is documenting treatment outcomes as you go along and using your clinical judgment in that sense.
Okay, thank you. There are a couple of questions in here about can therapy assistants take LSVT BIG? And yes, thank you for pointing that out. So the LSVT BIG training is open to physical therapy assistants and occupational therapist assistants as well as PTs and OTs. The same would be for LSVT LOUD. SLPAs can take the training and certification course. Cynthia, question is this can this work for those who have had a stroke, which might affect their speech?
Yes, and in fact, I would put that in a similar category as the primary progressive aphasia question we just had. Oftentimes, the dysarthria or motor speech component post-stroke can be improved by LSVT LOUD. It's typically not the first thing that many individuals post-stroke need, cognitive, swallowing, language, but as those begin to improve, sometimes the dysarthria becomes a challenge. We do have a few published case studies that have actually looked at LSVT LOUD for dysarthria post-stroke, and we use the same format, a stimulability testing trial treatment, and for some individuals, it may actually be quite helpful.
Okay, great. Rachel is wanting to know if we're going to do any training in the UK.
Yes, we are. We have an LSVT LOUD certified training course coming up in London on June, I want to say 19th and 20th. I'll double check my schedule here. And yes, in Queen Square in London on June 19th and 20th for LSVT LOUD. For LSVT BIG, we're actually gauging interest in a course. And so if you're interested, let us know. That course is tentatively scheduled to be held in July in Birmingham, and that would be July 11, 12. So that one is not scheduled yet, but if there's enough interest, we will definitely be scheduling that. And also, the course can be done at any time online. So if you're UK based or somewhere else based and you're anxious to think about getting the training, the full course can be taken for either LSVT LOUD or LSVT BIG online.
Okay, thank you. There's one other question about if we're going to do any seminars here in Alberta, Canada for LSVT BIG. So same response. You can do it online at any time. Right now, we don't have a course scheduled for Alberta. However, if you are interested in learning about bringing a course to Alberta, please email us and we can give you information on how that might work for you. And with that, I believe that there are no other questions for this webinar, and we are a minute after, so we just thank you all for joining us for this webinar. We hope that you enjoyed it. Please do remember to fill out the survey, and we hope to see you for our next webinar starting in 2020. Until then, happy holidays to everyone who's celebrating. Goodbye.